All right, let's continue. This is the last lecture of the movement disorder series, and then we're going to talk about a few conditions in the category of hyperkinetic movement disorders. We're going to start it with essential tremor, which is a neurologic disorder characterized by rhythmic, involuntary shaking of parts of the body. It is considered the most common movement disorder and may affect about 10 million of people in the US and to be 20 times more prevalent than Parkinson's disease. And the age, the typical presentation for ET can be found in younger patients in the 20, 30, but also more common in older patients, such as the 60 years old or above, and is estimated to have a prevalence of 6.3 to 9%. That's almost 10%. It's a very common condition. The clinical features of ET and the presentation usually started with the limbs, usually the hands. When the hands are in active use, the so-called action tremor and or postural tremor. And although we said it's commonly in the arms, but may also affect the head, voice, chin, tongue, and legs, the severity may vary significantly depending on the type of movement. Typically, tremor can be exacerbated by stress, by anxiety, such as patient in front of people. Sometimes stimulants such as caffeine can exacerbate the tremor as well. Interestingly, alcohol seems like to be able to relieve the amount of tremor, so that's usually part of the history-taking process. We always ask if alcohol can actually help relieve the tremor. If yes, that's another evidence this could be ET. Family history is very common, and about 50% of patients with ET have positive family history of tremor disorder. The main indication for treatment is functional disability. In another word, if the tremor is mild and doesn't affect the patient's function, you don't have to treat. And here shows a spiral joint for normal, and then patients with ET, you can see the shaking, the disable, and the joint. Differentiation of diagnosis of ET includes a tremor secondary to other systemic disorders, such as some patients with enhanced physiologic tremor when they are nervous, and medication can induce tremor. A thyroid disorder such as hyperthyroidism can have a tremor, among other symptoms. Blood sugar fluctuation, hypoglycemia patient may have a shaking episode, or excessive use of caffeine or other stimulants and may cause tremor. Tremor can also be seen in other neurologic disorders such as Parkinsonism, stroke, traumatic brain injury, multiple sclerosis, or neuropathy. The treatment of ET typically can be started with a non-selective beta blocker. Propranolol is the most common used medication to treat essential tremor with good evidence. Primidone is a type of seizure medications and that has been widely used to treat essential tremor. Other options including biclofen, gabapentin, mirtazapine, pregabalin, and topiramate, and has been described as effective in some patients, but results has not been very consistent. Oftentimes, patients may need some occupational therapy education in order to cope with the tremor. In severe medically refractory tremor, there might be a role for different stimulation for this type of tremor. And this is therapeutic algorithm in essential tremor, and you can review. I'm not going to go into the details. Deep brain stimulation, again, can be used to improve tremor that is medication refractory, and the target for essential tremor for DBS is the ventral intermediate nucleus, VIM, of the thalamus, and it can lead to 80% of improvement in tremor and 70% of improvement in handwriting. And here's again, you can see the patients with DBS, and when you turn the DBS off, the join and handwriting is like this. But once you turn the DBS on, you can see the tremor is gone. The writing is much more steady and stable. Touch base a little bit about another Korea disorder, the Sydenham Korea. This is a child, pediatric movement disorder, typically develop weeks or months after a group A beta hemolytic streptococcus infection. Patient can present with chorea, inattention, OCD-like symptoms, paranoia, reluctance to speak, and oftentimes accompanied by systolic heart murmur, arthritis, subcutaneous nodules, as part of the rheumatoid fever. And you can check ASO, ADB, and with echo MRI to find other evidence of rheumatoid involvement. The treatment for Sydenham chorea is typically, if severe enough, then you can use steroids or IVIG, and Depakote, tetrabenazine, and dopamine blocking agents has been used to treat the chorea as symptomatic treatment. Dystonia, as we said earlier, is a hyperkinetic movement disorder that results in sustained muscle contraction causing twisting movement or abnormal posture. It may occur as an isolated disorder or on a genetic basis or as part of another movement disorder. The common focal dystonias seen in older adults are cervical dystonia, and blepharospasm, the excessive eye blinking, and spasmodic dysphonia, and or focal hand dystonia, writer's cramp, and are common in adults. And usually the treatment is anticholinergic medication or muscle relaxant such as biclofen, and but the improvement of symptoms is typically limited, and that's why Botox injection has been the gold standard for treating focal dystonia syndrome. There are a lot of primary generalized dystonia syndrome with hereditary background, and the common one is the DYT1. It's an autosomal dominant genetic disorder, and the clinical penetrance is only 30 to 40%. That's why you may or may not have a strong family history. All cases are due to a single GAG deletions, and it's encoding for glutamic acid in torsion A on chromosome 9. The torsion 8 is a heat shock ATP binding protein, and the mutation causes dysfunction of the protein. The typical age of onset is in the first decade, often affecting a limb, like the leg or arm. The risk of spread of dystonia is related to age, higher risk in younger patients, and the site of onset, higher risk in legs, and initial symptoms of leg, and the higher chance it's going to spread. Dopamine responsive dystonia, DYT5, is another generalized dystonia syndrome. It's autosomal dominant with reduced penetrance, higher in female, and the answer is usually in the first decade of life, typically affecting the food, often with diurnal variation, which means worse later in the day, better after sleep. And the reason we talk about this disease is, it does respond to low-dose levodopa or anticholinergic medication very well without the development of motor fluctuation or dyskinesia. as far this is considered a treatable dystonia syndrome, you don't want to miss. And as a matter of fact, and oftentimes when we see a child with dystonia, even though we don't know what's the cause of the dystonia, sometimes it's worthwhile to give the patient a trial of levodopa in order to say, to serve as a treatment trial. This is a picture of a generalized dystonia with limbs and trunk dystonia with different posturing. This is a much more severe case. Tourette's syndrome, it's inherited neuropsychiatric disorder with onset in childhood characterized by multiple physical motor tics and at least one vocal phonic tic. It's more common in males. It can occur about 10% of kids and has complex genetic etiology believed to be due to corticostriatal thalamocortical circuit abnormality. And dopamine, and GABA, glutamate, serotonin has been studied, believed to be involved in the disease process. And usually Tourette's syndrome comes with a lot of mood disorder, depression, ADD, OCD, as part of the disease spectrum phenomenon. The management of tic disorder usually by education and counseling, that in order to have the patient to better cope with the disease and make sure the patient's supporting system is good and people understand the nature of the disease. If the tics are troublesome, and then it can lead to non-pharmacological and pharmacological treatment, including cognitive behavior therapy and medication for severe case. And also there's a need to treat comorbidity of psychiatric conditions and a behavior disturbance. Restless leg syndrome is a condition that patient feels an uncontrollable urge to move the legs at night, usually accompanied by an uncomfortable sensation of the legs that worsen with inactivity and improve with movement. That's typically the patient feel discomfort in their legs and to the point they have to get up walking around, and then they feel better after they get up walking around. Symptoms occur while the person is awake and may also involve their arms. Usually, you don't need to do a sleep study in order to make a diagnosis. There might be family history of the similar conditions. There's another condition called periodic limb movement disorder of sleep, PLMS. This is an involuntary limb movement while the patient is actually in sleep. It can occur in 80% to 90% of patients with RLS, but keep in mind the PLMS is not specific for restless syndrome. Many medications may aggregate or induce restless leg syndrome. Typically antipsychotics and tricyclic antidepressant, SSRIs, lithium, antihistamine, and dopamine antagonists. And those are all common things like caffeine, smoking, alcohol, all can exacerbate restless leg syndrome. The treatment for RLS is indicated if symptoms are severe or significantly interfere with the quality of life. And there is a room for dopaminergic agents such as dopamine agonist, and even in those of dopamine agonists such as pramipexole or repinolone, about 1 to 2 hours before bedtime is effective. And also sometimes you can use carbidopa-levodopa off-label and may be effective as well. An extended release form of gabapentin and pregabalin has been studied and believed to be effective. And there's also secondary iron and restless leg syndrome related to iron deficiency. And in those patients, usual symptoms may improve with iron replacement. So as part of the workup for restless leg syndrome, you try to check the iron level and make sure there's not iron deficiency, because the treatment may be, drug-induced movement disorders can, be caused by, antipsychotics, and, sometimes can cause acute dystonia. And for chronic treatment patients with antipsychotics, chronic reversible drug effects can be observed, including action tremor, Parkinsonism, chorea, dystonia. And specifically for tardive syndrome, which is a chronic irreversible drug effects or tardive phenomenon, often begin after the medication. Usually antipsychotics has been used for weeks to months. Movement disorder can include typically oral buccal dyskinesia. Those are the involuntary movement around the mouth area, dystonia, akathisia, or myoclonus tics. Typically, the treatment for tardive dyskinesia and tardive syndrome is to prevent the occurrence of TS by strict selection of patients to treat with dopamine receptor blockers. Try to avoid long-term treatment, or try to monitor the emergency of tardive syndrome if you are treating those patients with antipsychotics. If a dopamine receptor blocker is necessary, consider starting switch to those with lower risk, such as second generation quetiapine, clozapine, if possible. There is always a road to taper down the dopamine receptor blocker, and but oftentimes may not always possible, and as oftentimes for psychiatric patients, they always need those medications in order to control their psychiatric symptoms. But in study and observed that spontaneous remission of TS oftentimes, can be observed in up to a third of those patients who discontinued dopamine receptor blocker, but only 2 to 5% of those who remain on, the medication. Try to taper it down slowly if possible. However, the longer duration of exposure to dopamine receptor blockers usually decrease the chance of remission. And the treatment for tardive syndrome, including the so-called ABC, anticholinergic agents, biclofen and clonazepam. More specifically, VMAT2 inhibitors we mentioned about earlier, including verbinazine, deutetrabenazine have been approved to treat tardive dyskinesia. In case of severe tardive dystonia, Botox injection can reduce the frequency and the severity of abnormal movement. All right, that's a quick round for the common hyperkinetic movement disorder, and this will conclude our movement disorder lecture series. And again, please, send me an email if you have questions. And thank you. Hope you enjoy the learning of movement disorder. Thank you.